So welcome everyone. Thank you for coming to our clinical case webinar. And today we have the Justice Health and Forensic Mental Health Network team with us to present on OAT and custodial settings. Can you go to the next slide, please? So first, we'd like to acknowledge the traditional custodians of the country on the lands on which we meet and recognize their continuing connection to land, water, and culture, and pay our respects to elders past, present, and emerging. Before we start, I'd like to just touch on the OTAC scholarships that we're having. Our next round of applications closes on May 29th, and this scholarship is open to unaccredited GPs and NPs in regional and rural areas specifically. And we'll also be having an OTAC session on the 6th of April in Sydney CBD. There's more information on the OTAC website too. And these are our registrations for today. We had some last minute registrations, so we have about 80 people. Over half are from the metropolitan areas, but we still have some good regional and interstate representation. And then the next slide. This is a breakdown of the specialties, a lot of general practitioners and pharmacists, but also representation from all the roles, which is great to see. So the clinical case webinars are monthly webinars that we hold on Tuesdays. We have different topics each month, and we will also send a certificate so that you can claim CPT points at the end. These webinars are also recorded and will be made available on the website. Just for a bit of general housekeeping, please keep yourselves on mute, and if you have any questions, feel free to type them in the chat. The Justice Health team will be monitoring the chat throughout this webinar. And turning it over to the Justice Health.
Great, thank you, Jessica and team. So my name's Craig Cooper. I'm the Service Director for Justice Health Drug and Alcohol Services. And with me today, we have Peter Thompson. Peter?
Yeah, hello. Hi, I'm Peter Thompson. I'm one of the co-clinical directors at Justice Health for Drug and Alcohol. So it's nice to be with you this evening.
And Katerina.
Hello, Katerina Lagios. I'm the other co-director. Hello, and yes, nice to be with you all.
So thank you very much for inviting us to come along this evening. What we're going to do is have a bit of a conversation around what OAT service delivery looks like in the custodial environment. And we're going to be doing that via 3 case studies, and to then also talk about some of the salient or pertinent issues for each one of those as we go through. As mentioned, I'm Craig, and the learning objectives for today's presentation and discussion is to just talk about what the patient journey looks like in the custodial environment and what some of the service delivery or contextual factors are that impact on OAT clinical practice. Some of the patient complexity issues will hopefully come through with the 3 presentations, for example, MDT care, pregnancy, and also finally the patient transfer of care from the custodial environment back into community providers. And drug and alcohol services in Justice Health is quite a mixed bag, even though tonight's presentation is predominantly around OAT service delivery, so depo-buprenorphine, Buvidal, and methadone predominantly. We have a range of services in the team, and we have a multidisciplinary team. So we have a team of doctors and nurse practitioners as our prescribers. And in that, with the addiction medicine specialists, we also have addiction psychiatry within that team as well. We have a large team of drug and alcohol nurses across the publicly funded correctional centres. So we have almost, I think it's up to around 50 nurses throughout the state. And then we also have an Aboriginal health team, which is a newly created team as a result of the SCI, the Special Commission of Inquiry into the Drug Ice, and an allied health team, as well as other support staff such as OAT release planning and also connections program staff, which are responsible for linking patients into care in the community for the first 4 weeks when they're released from custody. So that's a range of some of the services. The main specialty area that we've been working on is around OAT service delivery specifically, and the OAT release planning service and connections program are 2 of our discharge planning and transfer of care services within the drug and alcohol team. Other specialist programs that we have is the drug court program, which operates out of the Hunter, Sydney, the Downing Centre, Parramatta and Dubbo courts, district courts. We have the compulsory drug treatment program, which is situated out at Parklea Complex. And we also have the Wallumer program, which is an Aboriginal diversionary program for up to 50 Aboriginal participants in any given year. As a part of the Special Commission of Inquiry into the Drug Ice, we had an injection of funding to set up what we've called the BIG program, so brief interventions and group work, which is mainly targeting or engaging patients early as they come into custody on remand, and also looking at complex care or MDT care issues. In the background, we have, for example, the OAT release planning service, which is predominantly administrative staff, even though there is a clinical governance function above that team. We have a range of data managers to actually support patient transfer, patient care and clinical service delivery, and also to ensure from a performance monitoring perspective, we're meeting all of our obligations. For the publicly funded program, there are 1,700 patients, and the split for those patients, 85% of those are on depo-buprenorphine and 15% on methadone, and that significantly reduced the proportion which are on methadone over the last 2 to 3 years. And at the same time, we have roughly 4 patients that it's clinically indicated around opioid use disorder. There's a waiting list of up to about 6 to 7 months. This is just some basic data and information for you around what the population in the New South Wales corrections system looks like. How many of those patients are seen by drug and alcohol services? A large proportion of all patients that come into custody would be outpatients. Ours is one of the largest specialist clinical streams in Justice Health, and of the proportion of patients that return to custody, it's roughly around 24%. So case scenario 1, I now hand over to Peter.
Yeah, thanks, Craig. And again, sort of welcome and good evening to all, and thanks for signing in and showing interest in Justice Health and drug and alcohol services and how opioid agonist therapy is provided within this setting. Just maybe as a bit of a background for myself, I'm working towards acknowledgement as a specialist in addiction medicine. I'm not a specialist in it at present. I've spent most of my career working in emergency medicine, and that's my sort of main specialty. And I sort of share that because, in a sense, I think that's representative in part, and with Katerina, who's got a background very much in population health and a broader context around sexual health. We're looking at trying to bring aspects of addiction medicine care, which are crucial and very specific at times, but also ensure that we do that within a good context of overall patient care and awareness. So we've got 3 cases we're going to present, and throughout each of them, I suppose there'll be similar questions that you'll always ask, similar questions we ask at any time when we're seeing a patient. And they're there sort of, Jessica's added in, sort of what are the clinical priorities, what are the clinical priorities we have with this patient, what are the things that this patient wants, what do I think as a clinician that I can provide, and then trying to do that with an understanding of what the context is for this particular patient at that time. And that, of course, may change during their journey. And then, of course, thinking in terms of whether the treatment we've provided, how that fits in and aligns with both the patient's priorities, our priorities as healthcare providers within Justice Health, equally the priorities of correctional services who are separate to Justice Health, but they look after the environment in which we work, and of course within the broader context of the community and society and what we're trying to achieve. So this patient Peng, and all of these are made up clinical cases, but with a lot of reality underpinning them. Peng is a 34-year-old gentleman who's came to Australia at the age of 13 from China and has had a range of sort of traumatic times as a teenager and as a younger adult. He's presented to us having been in hospital for a couple of days, but his primary drug of choice has been as a polypharmacy use with sort of methamphetamine, vice use, cannabis, benzodiazepines, predominantly diazepam, and with an occasional sort of opioid use, occasional use of heroin, which he smoked. He injected ice, pretended to smoke the heroin occasionally. Now, he came to us having been in hospital, as I said. He'd been by the emergency department because when he'd been arrested, he was behaving aggressively and was quite agitated. And it turned out when he was in the emergency department that they took further history, of course, and found a history of anxiety, depression, for which he'd been taking metazapine for a prolonged period of time. And he'd also had previous presentations at other hospitals for psychosis, which was felt to be related to his ice and his cannabis use. And he had been intermittently on doses of olanzapine, 10 milligrams twice a day. So once he'd been stabilized from having been arrested and taken to the emergency department because he was quite agitated and aggressive, and then he'd settled down from their perspective, he was then transferred back into the care of the police and brought to our reception center, where at our reception center, he goes through the process of coming into correctional services. And at the correctional center, he'll have an assessment by a primary care nurse. And so the primary care nurse gets that history, has a bit of a discharge from the emergency department in terms of a report of anxiety, depression, has a history that he'd been on some metazapine, erratically taken, but on 30 milligrams at night, and the history in terms of olanzapine. The acute agitation and the acute intoxication that he'd had sort of settled from his time in emergency. And so the situation then, in terms of the process of care, is we have a primary care nurse who's taking this history, identifies a significant drug and alcohol component, and then contacts one of the drug and alcohol specialists through a service called ROAMS. The ROAMS service is available 24 hours a day. So it's available in the daytime between 8 and 4 with a rostered specialist or nurse practitioner available to take calls and provide phone and telehealth support and advice to the primary care nurses who are doing the initial assessment at reception when inmates or when prisoners are brought in and become our patients within Justice Health. So the patient at this stage had normal vital signs and had no signs of intoxication. And with his history and with the concerns, the options are, where is that patient being cleared at that stage and just allowed to go to a cell? And if he's in a cell, he may well be in a cell for 23 hours a day with sort of minimal input. Or more frequently with the drug and alcohol patients, of course, where there's concern about how they may proceed, they'd be in a monitored cell or an observed cell, a camera cell, where we're able to identify if there's any change in the condition of Peng in those early hours or in that first period of time, as we look to try and build a few dots along the pathway of assessment to see, is he remaining stable? Is he changing? Is he altered? Other aspects of his presentation which are concerning. He had a fairly settled time. He came to the reception center. Then from that reception center, he'll then be moved around within correctional services. There are multiple correctional facilities around the state where he could end up. But from reception and the input from the ROAMS drug and alcohol service, giving advice, suggesting a review, having frequent phone calls or reviews on a daily basis to see if the patient remains stable. And then at the same time, the primary care nurse would engage with the on-call mental health services with regard to his other medications in terms of metazapine and so forth. Peng progressed through the correctional facilities and he ended up on the South Coast, Now, he didn't have access to his normal pharmaceutical use in terms of his ice use, and the access then to Suboxone, which is a challenge and something we'll probably talk maybe a little bit about in terms of access to drugs in correctional facilities, is something that became available to Peng, and he started using Suboxone. And he started injecting Suboxone in facilities, and then having been seen initially by a drug and alcohol nurse at his initial assessment with regard to his drug use, he then was reviewed, and it became clear that he developed an ongoing dependency on Suboxone, and he'd been injecting it, and with shared needles and shared facilities, we went then through a process of assessment with population health to check for his hepatitis C status, which was then found to be positive. And then he goes through a process of workup and clinical assessment for treatment for his hepatitis C, which he went through and had a successful outcome with his hepatitis C treatment, which is all quite positive. Having gone through that process and having identified himself as someone who had become dependent upon Suboxone, it then gave us a chance then to reassess and see about getting him onto treatment to help that dependency. So the drug and alcohol nurse and referral through the drug and alcohol specialist who sees him. In view of his medications, he was on mirtazapine and also on olanzapine, on an antipsychotic, which he'd remained on. And due to the concerns around sedation and metabolic impact of those medications, we then have developed over the past few years a process called multidisciplinary team assessment. So for those patients who are on sort of active use of psychoactive medications through their psychiatric care and are looking to commence opioid agonist therapy, and the concerns around sedation and the complications that can occur from that, we then go through that process where we get an in-depth sort of pharmacy review of the medications, as well as mental health assessment to see whether those medications are indeed ones that they want to continue with, or whether they wish to rationalize that therapy, whether they want to reduce the sedative medications or indeed change them around. So we go through that multidisciplinary team approach, which is done predominantly through remote assessments and through email correspondence to align the various care priorities from the various teams. And that having been completed, we're then in a situation to commence them on an induction for Buvidal therapy. As mentioned previously with the information that Craig was sharing, 85%, the vast majority of our patients will go through to depot buprenorphine, and we can discuss as to why that is preferable to the alternatives during this evening. But I imagine some of you will have views upon that as to why we may choose to do that. So his induction, we tend to do, because he's on sedative medications, we do a modified induction, partly because they're in a relatively confined space and a limited sort of oversight while they're health oversight while they're in the correctional facilities. So we do a modified induction, which is a low dose on one day of Suboxone, 2 milligrams, and then we tend to do subsequent days at 4 milligrams, and then move them on to a weekly of 8 and then 16, and then move them on to the monthly dose. So it's a slow progression of a slow increase of their buprenorphine dose until we get them to a suitable monthly depot preparation, which satisfies them in terms of controlling their dependency and can keep them stable. And I suppose that's been developed over the past several years where, and I wasn't working with Justice Health at the time, but Justice Health was sort of one of the very early adopters of the use of Buvidal. And so that slower process to commencing and inducing and inducting patients onto Buvidal is something that's worked quite well, particularly in those who are potentially at higher risk of sedation and complications. So that pretty much summarizes Peng. There are a few questions that come up after that. If we move to the next slide. I think there are some questions in the chat, and I suppose it gives an opportunity for people to share their thoughts. Here we go, some questions.
So the question in the chat is around, in the early 90s, there were about 6,000 inmates in New South Wales, and about 10% on OAT, which was methadone only, started specifically as an anti-HIV strategy. How come with this much funding and staffing levels, there is a 6 to 7 month delay, And what is the seroconversion rate for Hep C or HIV in that pre-OAT period?
Great. Well, some of that actually, some of the information around hepatitis C, I haven't got HIV data to hand.
Well, no, let me just
yes.
say there really is, there's been one person with that had developed HIV whilst in custody, and that was a very long time ago. We haven't had anyone who's developed HIV related, we haven't had anyone who's developed HIV whilst in custody, and definitely not related to injecting drug use. We have had one other person who came in new to custody, and we identified HIV, and they did have HIV related signs and symptoms. So HIV is very well managed. Hepatitis C, so you're wanting to know about hepatitis C pre-opioid therapy, pre-Buvidal therapy, or post? So pre-opioid therapy, 50% at least of our patients would have had hepatitis C exposure, with many people hepatitis C, PCR positive and requiring treatment. In the current era, and this is to do with the directly acting antivirals that have been so successful, and so easy to take, we are actually finding dwindling numbers of new hepatitis C cases. Not zero, but previously there was a 50% finding or 40% finding. It's gone down to under 10% at the moment, but that doesn't mean it's not occurring. It is still occurring, and it is related to injecting drug use risk behaviour.
Great, thank you. Moving on to the next one, Peter.
No, there's another question, I think, wasn't there? Was the second question around the access to Suboxone in custody.
Suboxone in prison. They often see people from Justice Health have been smoking Suboxone in jail. A patient today reported starting himself on bupe in jail with the Suboxone strips. That's a whole story.
It is. I mean, that is one of the challenges. It's a huge challenge. I think, both Katerina and myself started in this role as a co-clinical director the middle of last year, so about 8 months ago, and it was certainly an eye-opener for myself in terms of the access to Suboxone within correctional facilities, and it's ongoing work between correctional services and ourselves, I think, to try and create an environment where it just isn't available. But I think the challenge we have here is similar to many countries, whether you're looking at, or certainly in the UK, where I've got a fair amount of contact with some of the custodial services systems over there, where Suboxone has become very, very prevalent and gets in through a range of routes, whether it's by drones, whether it's being thrown over walls and wires, whether it's through visiting, whether it's through staff who work at. It's become a great location for criminal groups who wish to progress their sort of drug business, and it's obviously a very captive audience. So it's a place that there's a lot of focus on.
And certainly, Suboxone is very popular in the Australian setting in custodial areas. So though it might be occurring in the UK, they have a bigger issues with synthetic cannabis and respiratory illness, and different health issues. But very easy to bring in Suboxone, not identified, not able to be sniffed by the dogs, and it's business.
Yeah.
So next case study.
Yeah, sure. So keep your questions coming, and we can sort of look at those towards the end as well. So the next case is a young lady, Katerina, 23 years old, from Indigenous abuse on entry. It was a story of using Rivotril, Clonazepam, 1 to 2 tablets a day, regular use of cannabis, and then also that she was smoking ice. She'd had some severe sort of lower back and abdominal pain over the previous 6 to 12 months, and she'd been getting Lyrica off the street as well as Endone off the street. And then in the previous 2 months had developed a use of heroin, which she was finding was helpful to help control some of her pain. Now, she came again via after having been arrested and brought to reception, having been through emergency because she'd been sort of unwell when she'd first been picked up by the police, was cleared by the police and was cleared through emergency, and was found when she was in emergency that she was pregnant. They did a beta HCG test as well as a bedside ultrasound, which confirmed that she was pregnant, not that she knew this, and there had been a history of seizures, and that's why we linked into the clonazepam, and that's why she had ended up going through emergency, and there was a concern that she was having seizures. But that was settled. She had an EEG, which was normal. She had a CT scan of her brain that was normal. There was no evidence of any seizure activity, and she was then discharged from the hospital and was back into the police custody, and then came to our reception centre where she was assessed. And again, similar to all our reception, she's seen by a primary healthcare nurse, and who goes through her history, gets the history in terms of her medications and the concerns that would be present with regard to irregular benzodiazepine use and her heroin use. She had a period in emergency, so her acute withdrawal symptoms had settled. So she wasn't in acute withdrawal. She was stable. She was able to be observed through a camera cell, was assessed further through drug and alcohol nursing and through drug and alcohol specialists. It was also because she had been confirmation of pregnancy by blood test was done again, and then she was unaware of her pregnancy, but that was obviously then informed of that, and she was then able to link in to the perinatal services for substance use in pregnancy service that we have, a SUPS team, which includes both psychological support through mental health, perinatal support, midwifery, drug and alcohol, Aboriginal, Indigenous healthcare workers, as well as social workers. And so that team brings themselves around the young women who are pregnant and helps to sort of devise a plan of trying to sort of stabilize them, which this lady obviously moved on to a program with had some Subutex prior to coming to us, but then moved on to depot buprenorphine as an ongoing opioid agonist therapy, which she did well, and then was being supported through the substance use pregnancy service to try and link in the best way to support her through a pregnancy, and clearly to look at options in terms of getting her to a suitable facility or manage her through her time in corrections and her time going to court, because when she comes to the correction service, she's sort of brought to the correction service essentially in remand. She's been charged, but she hasn't gone to court yet. And so the whole process then of trying to support her through the multidisciplinary team around the SUPS program with midwifery, social work, Indigenous health workers, perinatal psychology and psychiatry, drug and alcohol specialists to stabilize the clinical condition and have her in the best condition, so when she does end up at court, we can be hopefully looking at the most positive and beneficial route for her to be able to progress her pregnancy in a supportive environment. So that's, I suppose, a bit of an oversight of one of our major teams, which is the substance use pregnancy service that we run. And we're reviewing patients, every day we're reviewing patients, but we have sort of a multidisciplinary team meeting every fortnight to look through the progress, and that coordinates the care between what we're doing while they're in corrections, also with our services in the community, where we can try and link suitable mothers, young mothers, into ongoing care when they're going to be released and discharged or released from correctional services. So that gives a bit of an overview of that particular case. We can move on to the next slide, Craig, thanks. There are a few questions that are present there as well, which give you a bit of an overview. These you wouldn't necessarily know, but I suppose the numbers of women in prison, which are low numbers, but they're still higher than they used to be, and the relevance of drug and alcohol support to those numbers of women. So, we're looking at several hundred women who are in correctional service at any one time, a large proportion of those needing the support of drug and alcohol services. And the proportion of pregnancies, as they were looking at probably about 100 or so a year that we have through the service, which usually has us reviewing probably about 15 women every fortnight in our multidisciplinary meeting, with probably about sort of 2 new situations of pregnancy coming into the service every week.
So just to add to what Peter's saying at the moment is we have been progressively and clinically now for a number of years trying to reduce the number of births in custody, so to ensure where possible that the babies are delivered in the hospital or back on country and in community, because a large proportion of the pregnant women are Aboriginal women as well. And noting that even though there are the pregnancy and the mental health issues, there are also a range of other issues. If you look at the 5th question on the slide around successful community reintegration, the big issue is around safety. There's a big issue constantly around trauma and also safety for these women. So it's not just about the pregnancy, it's about, in terms of holistic care, ensuring that all of those issues are being attended to in one way or another. Sorry, Peter.
And that's quite true. Quite often when we're having our discussions around these patients, it's felt that actually we can provide, we find we're able to provide the safest care and the most complete care while they're under our care within Justice Health. And I know that it does sound pretty rather controlling, but the concern is that when they are released, and sometimes there are sort of unexpected releases that occur, when they are released, trying to ensure that network of support is in place, sometimes there can be gaps in that. So that's a concern, because they are quite complex, and as Craig was mentioning, particularly around violence issues.
So Peter, there's a question from Frank in the chat around what gave you the confidence to use Buvidal in pregnancy?
Yeah, no, that's a good question. I mean, historically, we've tended to use methadone, which would be the case. But I think, certainly, I suppose my practice, where I'm mainly working in Southwest Sydney, and the experience that I've had, if we have women who have sort of no other particular sort of medical complications, we haven't really had much problem with Buvidal. I know it hasn't necessarily gone through all the clearances that some expect, but I have never had any sort of problem with Buvidal in pregnancy when we've been using it. Obviously, we use sort of Subutex to induce them and then tend to get them onto Buvidal.
That's what the previous clinical director's pathway had been, that you were using Subutex, and it is the same medication and provides better, stable levels and safety in terms of what we're providing in a custodial setting. We'll talk about some of the security issues with the daily medications, and it was felt that that would move on to a better way. And in fact, we also had women, I think, coming into custody who were already on Suboxone and were fine, or had been started on Buvidal and were fine. And so there was an element of a feeling that it was relatively safe and probably provided better stability to get through the pregnancy.
So there's a comment from Frank saying, it sounds like you have not met the coroner yet. I have met the coroner, and around this issue though, Frank, no, we haven't. The other issue around medication supply in the custodial environment, we also have our chief pharmacist, Anthony, online as well. So if there's any questions around from a pharmacy perspective and also medication administration, even though we drug and alcohol services do the assessment and also prescribing and the reviews of the patients on OAT, the administration of the medication is actually taken care of by our primary care team. So we don't do the medication administration. That is all taken care of by another team. Is it all right if we move on, Peter? Yep.
Yeah, no, sure. That's good. Any other questions you've got there, or not really? No, just about the coroner. Okay.
Yeah. So the next scenario is around Steve. He's a 52-year-old man, and he's had repeated engagement in the criminal justice system, and he's been going in and out of custody since the age of 13. Steve has been on OAT 6 times and the first time he started OAT was when he was 19. And his primary drug of choice is heroin. Steve has had consistent problems finding and securing accommodation and independent leaving. And Steve's now been in custody again for 3 years and was on OAT when he entered custody and has contact with his family and children. So his OAT story for Steve, he's currently stable and he's been referred to our program, which is the Connections program. So the Connections program is a linkage to care program. It's not a case management service. It's a linkage to care program. So we get referrals for Connections at any time when somebody, and it's for planned releases, not unplanned releases. So roughly about 20% of releases from custody are unplanned. So the referral to Connections can be made by themselves or by another staff member, Corrective Services New South Wales staff member, or Justice Health staff member. It doesn't have to be a drug and alcohol staff member. So a referral can be made, and around 6 weeks out from the time when the person's due to be released from custody, the referral will be triaged and the person will be allocated to one of the Connections staff. The Connections worker will then contact the patient and do a full assessment with that patient, and in that process they will do a care plan, a linkage to care plan. And for somebody like Steve, a part of that would be, even though he's stable on OAT, a part of the conversation would also be about take-home naloxone for opioid use disorder. So whether he would be prescribed that or not, I'm not sure about that. Katerina or Peter could talk to that. But in terms of exploring those issues, in terms of overdose risk, because the main issue around the Connections program, the reason it was set up over a decade ago, more than 15 years ago, was to prevent morbidity and mortality with the first week when people are released from custody and re-enter into the community. So Steve is stable. The referral's been made to Connections 3 months ahead of his release from custody. And during the assessment, Steve indicates that he wants to return to the Inner West and receive Buvidal, and he wants to go back to being administered Buvidal at a pharmacy that he's familiar with. The other main issue for Steve is going to be stable accommodation and also employment and finance considerations. And Steve has identified those during the assessment process and as the case plan has been determined. Now, unfortunately, Steve in this instance wasn't able to get stable accommodation straight away, so he ended up going into a boarding house for a period of time while he's on priority housing waiting list. But fortunately, at the same time, he was able to go back to his pharmacy of choice and also was able to secure employment. So for the Connections program itself, the main issues are around overdose risk and making sure the person is stable and engaged and connected to care when they get back out into the community. And if they're not, consistently accessing OAT care back in the community, then the worker will be actively following up with them around take-home naloxone. The accommodation is always going to be a big issue, especially for somebody who hasn't had stable accommodation and has been in custody for an extended period of time. And the treatment continuance is also going to be an issue. A lot of people get out of custody with not much clothing, no ID, and the Connections program, even though it's not a welfare service, it's a health linkage program, will be able to help them in one way or another around a lot of those issues. Other issues that come up are around family support, especially if there have been an AVO out previously, or if there have been child protection issues raised in the past between the person being released from custody and also their family. Other alternative options as people are released, there is a post-custodial support service. There's a case management program that's also run by the Community Restorative Centre, CRC. There's Aboriginal community controlled health organisations that provide support services, and there's court diversion programs such as the Merit program or the Wallaman program which may be suitable for somebody like Steve if he ends up reoffending, but the severity of the offence may not be as such where he could be diverted away from coming back into custody and be managed back in the community. The significant issues from social determinants of health are around family and friends, access to health services, debt recovery if he's got some debt issues going on, continued risks around AOD use and also mental health. The significant issue around stigma because he's a repeat offender and been in custody recently, and also has a drug and alcohol issue and potentially mental health issues. The stigma is going to be a big issue, especially around accommodation and also employment for someone like Steve. Any questions about that, the Connections program or that type of scenario? So that's it. I
was just getting back to, going back to the other question around the coroner, just around respiratory depression with Buvidal in pregnancy, which I think may have been what Frank was alluding to. But it's always a risk-benefit assessment, and of course, all the deliveries in hospital require prolonged neonatal observation for respiratory depression. So I think it's about being aware of that as you move forward and expect that as you move forward with the pregnancy. So I just started to butt in there, Craig, but just wanted to try and close off that question.
Yeah, no.
I'm just going to add a component. Unfortunately, for our patients, there's a lot of what's called standover. So if someone is on Suboxone or Subutex, there are other people that will try or force them to hand that over for their use. And so we want our patient to maintain a stable situation being on opioid therapy, and we cannot always be assured with that if we're using daily dosing.
And there's a comment in the chat from David. It would be very helpful if patients on recent release were able to access a time-limited increased rebate for GP care. Primary care and access to primary care providers in terms of rebate or bulk billing is quite an issue for some areas.
No, that's a very good point. So yeah, it's a big issue when you're trying to link patients back into getting the plans that they need and trying to encourage them within the community to engage around mental health care plans and ongoing support. And most of all the public drug and alcohol services are able to link patients through obviously to counselling and other support systems, but the primary care component is crucial. And often, of course, then the drug and alcohol centres in the community can become a poor substitute for that, where they'll come looking to get whatever care they can through their community opioid treatment program.
So just back to some of the issues around the interdependency of service delivery with corrective services in New South Wales. It is quite difficult when there are lock-ins and there is limited patient access. When patients are transferred from one correctional centre to another. So there's constantly negotiation that needs to occur around patient access and so that service delivery and patient care can be delivered. So it's a bit of a tricky environment, and you don't have the amount of time that you could in the community in terms of how you access patients and how much time you've got with patients. It's a very different type of operating environment. And some of the resources that could be useful to have a look at if you haven't already had a look at them on the screen right now.
Thanks, Craig.
Oh, so do you want to take that?
Yeah, sure. These are just additional resources like SafeScript, which we had a webinar on last month, the recording's online, and also some contacts for local AOD services and DASAS.
Okay, so, and there's also another question in the chat from Frank, or a statement. Information from Justice Health to the community prescriber does not occur. That I don't know about that, Frank. In a lot of cases, we try and make sure that the script, the treatment summary, the patient information, the ID sheet, we have a battery of documents that accompany the patient to the community prescriber or the community dosing point, depending on who that is. The times that is less likely to occur, or could be a problem, is when it's an unplanned release. And typically, if that does occur, like I said, up to 20% of patients are sometimes unplanned release.
Some people also have an unplanned going to a different centre than where we've organised. That occurs. Right. You do everything, and then they were a completely opposite location, Queensland or somewhere unusual.
Yeah, so we've had cases, for example, where we've tried to arrange for them to go to the Central Coast, and they've ended up down in Bega, or vice versa. They've gone up to the Northern Rivers, and then for some reason they've ended up out at Golden. So we do try wherever possible, and the issue is we do have a contact number and email address for OAT release planning, so that the prescriber, the dosing point, the patient can ring up straight away if an unplanned release has occurred or the information hasn't gotten to where it is, and we can get that information to that alternate point pretty fast. So just to clarify that. Sorry, Jessica, I cut you off.
There's some more comments in the chat if you'd like to look at those too.
I'm wondering if how can people listening in contact us if they do require information related to recent opioid dosing and details?
We can put resources on the website along with the recording of this webinar.
Is that okay, Craig?
Yeah.
That'd be good. That'd be excellent. Yeah, definitely.
Do you want me to go to the next slide, Jessica?
Yes, please. So this is the last slide. Next month, we will be having another webinar on providing harm reduction services to people receiving OAT with Dr. Marissa Capetta and a peer representative from NUA. And we are finishing a little early. If anyone has any questions that they want to put in the chat or unmute themselves to ask.
Craig, I actually sort of had a question, and part of this might be because I had to quickly pop out of the webinar because someone called quickly that I had to answer. But in terms of in custody, with the provision of harm reduction services, things like fit packs, I think many of us are well aware that, NSPs don't, at least in New South Wales, really exist in prisons. Does that, obviously that can very much hamper, people from acquiring bloodborne viruses and things like that. Do you, I suppose, crystal ball, do you ever foresee that changing? Probably not.
I think the political climate around that type of change, I think there could be, so this isn't to try and give anyone any false hope, I think there could be a bit of a shift around that. But in terms of the likelihood of that potentially occurring in terms of NSP in a custodial environment, the likelihood of that happening in the near future is pretty slim. And it's not that there isn't the evidence, and it's not that from a harm reduction perspective that's not seen as being a good thing or the right thing to do. It's just the operating environment is pretty cautious around the introduction of NSPs in New South Wales. So there's quite a few more things that still need to be worked through around that. Katerina, do you have any thoughts about that? You're on mute. You're on mute. You're still on mute. Oh, okay. Yeah, so it is a big issue, Daniel and Dan, and unfortunately, we don't have a magic wand or a crystal ball to fix that right now. It has been identified as a priority. Katerina is now off mute.
Yeah, so it does exist in very small prisons, very where it's easily managed, and certainly in terms of logic, it would be the best thing to prevent needle stick injuries to officers that cause serious problems, which are what they're concerned about, and prevent infection happening. But you've got to remember that it's more about the dynamics and who makes decisions about control, I believe, which is why it may never happen. And yeah.
And there's another question in the chat from Frank. Thanks, Frank. They're good questions. But I'm not sure what the answer to this one is. So does the 3+3+3 system still exist?
I'm ignorant of what is the 3+3+3 system.
I don't know what that is either. Sorry about that, Frank. Good question, but I'm not sure what that means. Do you want to come off mute and ask? No? Okay. All right, over to you, Jessica.
Well, if that's all for tonight, then I'd like to say thank you, Craig, Katerina, and Peter, and all those who helped on the presentation.